request Dr. Narasimhan sir to give a talk, then finally I'll complete my talk.
Sure.
Dr. Narasimhan, Senior Consultant Pulmonologist from Apollo Hospitals, he'll be talking on adventitious sounds. Professor Narasimhan sir.
Yeah. Hello, good evening to all of you. Can you hear me?
Yes, sir.
I'm audible, pardon me?
Sir.
You are audible, sir.
Very well audible.
Yes. Okay, yeah. At the outset, I thank Dr. Parni for this wonderful opportunity and also appreciate for organizing this kind of academic events for the benefit of postgraduates. And I have been asked to talk on adventitious sounds in respiratory system. I've been a pulmonologist. I'll be talking about the adventitious sounds. Nowadays, there is a general belief among the medical students and the postgraduates and the clinicians alike that clinical examination is not necessary at all with the advent of all these investigations like the X-ray. In fact, chest X-ray is considered to be complementary to a clinical examination. You need to have an X-ray chest along with the clinical. The order has become like that now. And with the availability of CT scans and other latest investigations, we have realized that things may not be necessary, but it's not always true. Many times you need to correlate the clinical and your radiological findings together to come to your diagnosis. I'll just give you some examples. In my short time of 15 minutes, I'll be talking to you about the adventitious sound. What actually are these adventitious sounds? By adventitious sounds, I mean that normal flow when the patient breathes in through the lungs, it enters the lung through the trachea, both lungs it enters, passes through the lung parenchyma, and he expires, it comes back. So that actually is the normal breath sound. Anything that is abnormal, that results from the unusual flow of lungs, air through the lungs is called an adventitious sounds. So what are the adventitious sounds that you can come across? You can come across crackles. One can come across wheezes. One can come across rhonchi. And one can come across stridor. And one can come across pleural rubs. These are the 5 important adventitious sounds that one should be very much aware of. There may be other adventitious sounds like the succussion splash, the coins. There are so many things are there which may not be really necessary for us to know, but one has to be extremely thorough with these adventitious sounds. First and foremost is the crackles. Let us take crackles. So crackle, how does and why crackles occur? How does crackle occur? So whenever the alveoli in the air, air in the alveoli is replaced by anything. It may be fluid, or it may be blood, or it may be an exudative, whatever is there. When the air is replaced with something other than air, maybe fluid, or blood, whatever, when you auscultate, you will get crackles. Similarly, the airway, the main airway, the larger airway, the bronchus, and the trachea, if they also should not have anything, it must be a very clear-cut passage for the air to go through. If there is something inside the airway, you will get an adventitious sounds. If it is a fluid-like thing, like I said, if it is an exudate, or it is blood, or a pus inside, it gets a gurgling noise. You'll get a bubbling noise, you'll get. And this bubbling noise would depend on where the sound is made. For example, if there is fluid in the alveoli, there is a distal part of the lung, there is terminal bronchioles, respiratory bronchioles, and alveolar ducts where you have the fluid inside, you will get fine high-pitched crackles you'll get. On the other hand, if you can hear a very coarse crackles, you get a very coarse crackles, it means the pathology is in the segmental bronchi, because it is higher, coarse, low-pitched crackles, if you can hear, it means the pathology is in the airway, probably has got bronchiectasis or something like that. Sometimes you can hear a bubbling noise. The patient will be brought into the emergency with a bubbling noise. You can hear the noise in the trachea, just a bubbling noise, fluid will be jetting out of the mouth. That means there is a lot of fluid in the lung. The pulmonary edema is so much because first in the interstitial edema, then it has got into the alveoli, then spilled over into the airway, then onto the trachea. That is, it has not been treated and there has been a delay in the treatment. So that is the advantage of a clinical exam. If you can examine the patient and put your steth on and then say that there is a bubbling crackles, it means it's a very serious issue. And the same score, if you can go and auscultate the bases and you find fine crackles, you can say that probably we are dealing with pulmonary edema. But then you need to differentiate as a pulmonologist whether you are dealing with a serious problem of a heart failure or a chronic nagging problem like an interstitial lung disease. This can be differentiated because pulmonary edema, the crackles occur because of hydrostatic pressure. You can ask the patient to bend forwards. When you ask the patient to bend forwards, the crackles would go to the basal region because of the hydrostatic pressure. In contrast, if it is an interstitial lung disease, when you auscultate the bases, when you ask the patient to go forwards, there will be no change in the crackle. The crackles just remain the same because the interstitial lung disease is a pathology in the interstitium at the alveoli. So the crackles do not disappear, unlike in pulmonary edema, where the fluid tends to move forwards and backwards depending on the gravity of the patient, which position the patient is in. There the hydrostatic pressure is more, and then there the transudation of fluid occurs into the alveoli. So that's said about the crackles. So you can have crackles. You can have them in the alveoli, you can have them in the bronchus, you can have them in the trachea as well. You can identify from the site where actually you are creating the crackle. If in a situation you are working in a peripheral region where you don't have an access to an X-ray immediately, or you don't have an access for a CT and other thing, a simple clinical examination will be able to tell you whether you are dealing with the problem in the lung parenchyma or in the airway or trachea or a serious problem. Immediately you should be sent to the hospital or not. One. Number two, having said about the lung parenchyma, let's come back to the major airways, that is the larynx and the trachea. They also form a part of the respiratory system. You can hear a stridor sometimes. When the patient can be brought inside an emergency, you can hear a breath sound that is very clearly heard, stridor. That is an inspiratory sound. When the patient is breathing, you can hear a sound there. When the patient is expiring, the sound is heard, but it's not with the same intensity as it is heard in the inspiration. Any inspiratory noise is considered to be a stridor, and this stridor occurs generally in a laryngeal obstruction or a tracheal obstruction. In a laryngeal obstruction, for sure, you have a stridor. It is an inspiratory noise, inspiratory obstruction that occurs as the air passes through the obstructed airway. It vibrates the airway, and that vibration sound, the reed vibration technology, what we call it as, that is the one that causes the vibration. Instead of the upper air, when the air enters into the trachea, a trachea has two parts, an upper trachea, there is an extrathoracic trachea and an intrathoracic trachea. The extrathoracic trachea behaves more or less like larynx only because the extrathoracic trachea is directly in consonance with the atmospheric air. So when the patient is taking a deep inspiration, there is a negative pressure in the trachea. So the air can compress the trachea and patients can have a difficulty in breathing, causing a stridor. In contrast, if you go down to the intrathoracic trachea, where in the thorax, in inspiration, there is a greater negative pressure. So the airway opens and greater positive pressure in expiration. So the noise is more in a extrathoracic tracheal obstruction. You will have something like wheeze only. So that is why I keep telling all that wheezes are not asthmas. Stridors can be easily identified because you think it is in the larynx, or if you put the laryngoscope inside, you can identify that this patient has a laryngeal obstruction or an extrathoracic tracheal obstruction. But the wheeze, if the patient is wheezing constantly and if he's not improving at all, it means he needs to have a look inside the airway. The clinical examination is very important. A persistent wheeze, a changing wheeze, and wheeze changing and coughing, they all become very important. So we spoke about the crackles, then about the trachea, and then about the wheezing. Wheezing occurs when there is an obstruction in the airways. That is maybe the common bronchus, the main bronchus, or the lobar bronchi, or a segmental bronchi. When the air is forced past an airway and the airway vibrates, and that vibration, depending upon the vibration, one hears a wheeze. So that's actually is called wheeze. Wheeze classically occurs in bronchial asthma, chronic bronchitis, COPD. You can diagnose straight away. But one should remember, clinical application of your knowledge is extremely important because, as I said in the beginning itself, when you have a patient who has got a wheeze and he has seen several doctors, he has not improved, his wheeze is persistent, he has used all the possible drugs on health, that's the time for us to look diligently for a foreign body somewhere else, which means foreign bodies can cause a stridor if it is in the larynx or in the trachea, or when it comes down to the intrathoracic tracheal region or the main bronchus region, which can commonly occur in children and in adults too. People who eat these fish bones or people who take these jarda pans and suparis, they can just go inside the sleep when they are on an alcoholic binge. You can slowly slip inside the lung parenchyma, get inside, cause wheeze and sometimes crackles too, because they can cause a distal obstruction and pneumonia. You can have crackles. So in a foreign body, you can have crackles, you can have wheeze, you can have stridor, everything you can have, unless you have your clinical mind out, unless you do your clinical exam, because sometimes the CT will tell you only as a consolidation. If you examine clinically, you may be able to find a wheeze and a crackle, which will alert you to the possibility that we are probably dealing with some kind of a foreign body. Then a CT scan will tell us a persistent consolidation that is there for the past 3-4 months. He has got 1 or 2 CT scans and X-rays showing a persistent shadow, which means he has got a foreign body. So crackles are helpful in diagnosing a clinical condition and also lead you to the place where you must go for a diagnosis. Similarly is a wheeze, similarly is a stridor. Then we go on to what is called a pleural rub, an important sign again, where the patient will come to you with chest. Most of us have a habit of examining the patient with the bunions on and the shirt on. Definitely, either you will miss pleural rub or you will overdiagnose that actually. Or sometimes we depend more on the chest X-ray, that when the patient complains of a chest pain, you will miss the diagnosis of a pleurisy, which can tell us so many points in our pleurisy can occur in several conditions like from pneumonia to tuberculous pleurisy to an acute empyema just before the acute empyema starts, or a parapneumonic effusion, or a pulmonary infarct. So many things. So the clinical story and the clinical examination is going to give us a lot of information if you disrupt the patient and examine the patient clinically and look for the signs. So what are the signs which I told you so far? One is crackles. Then I spoke about the stridor. Then I spoke about the wheezes. Then I can also speak about the rhonchi. There are some people who club both rhonchi and wheeze into one, and I'm one among them. But there are some people, Kovacs and others, who are in books and who are in books on adventitious sound, have differentiated the two because the rhonchi can occur in the main bronchi and the wheezes can occur in smaller bronchi and so on. But I don't think that there needs to be such kind of a splitting. Whenever there is an airway obstruction and the air is forced past an obstructed airway, the airway vibrates and creates a sound which may result either in a rhonchi or in the wheeze. The only difference is the rhonchi is a persistent rhonchi in the main bronchial infrastructure. It will point you to a problem there, maybe a malignant tumor there, or maybe a foreign body there, or a bilateral extensive wheeze across it just means that it is in a smaller airway. It's a bronchial asthma. The patient has got probably the smaller and the smaller bronchi that are affected. So you have crackles, you have stridor, you have rhonchi, you have wheezes, you can have rubs. And lastly, one adventitious sound which I'll be talking on for about a minute is a vocal resonance. So vocal resonance is something where when the patient makes a noise, the sound is transmitted from the larynx down to the chest wall in the same manner. And if the patient has a consolidated lung, what will happen is when the sound reaches the lung parenchyma, the sound is different and multiplied several times, and that sound multiplied sounds, echoes that are important to the lung sound can be heard in a different manner in a vocal resonance. So in a consolidated lung, you have an increase of vocal resonance. In contrast, If you have a pleural effusion, because the fluid is there, when the sound reaches from the lung, from the vocal cords to your the chest wall and the pleural surface interface, the sounds are totally internally reflected. You don't hear any vocal resonance at all in this patient. So vocal resonance can be decreased in effusion, increase in pleural effusion and consolidation. Sometimes when the bronchus is split, what do you mean by that? At the interface, sometimes what happens is the refractive index of the pleural effusion and the lung parenchyma and the airway can be the same. At that time, the sounds can be passed through on a pleural, passed through the airway onto the chest wall and then onto the ear, making us feel that the air resonance is either normal or slightly increased. That's why when you aspirate this fluid, and next day when you come in the PG says, I'm able to hear, I heard the increased resonance. Today it is not there. It means the refractive index has changed. So that is how we apply our theory knowledge, the clinical knowledge, and try to come to a conclusion in a clinical situations. I really thank our Dr. Parani for having asked me to talk and share some of my thoughts on adventitious sounds, though they are gradually becoming redundant. And I'm sure, and Parani himself has organized recently a talk by one of the Royal College presidents who said that clinical examination is more relevant today than in the past. Thank you very much. Thank you all.
Thank you very much. A wonderful clinical talk, sir. Very nice to listen to such a wonderful clinical talk. Thanks again. And sorry that my talk got missed in between. So I'll complete it in 10